All right, we are live, and I'm just looking to see where I'm going to get questions on here that I cannot see. Um, hmm. All right, let's just. All right, well, let's start off. And I'm going to introduce our wonderful guest, Dr. Curtis-Nickel. And he is a leading global key opinion leader within the space of inflammatory disease and infection of the urinary tract. He's a past president of the Canadian Urological Association, has been a member of the Department of Urology at Queen's University since 1984, has over 625 publications, has been on the editorial board or editor of 12 urology journals, and has presented in over 50 countries. Is that even more now? Probably yes.
Maybe a few more.
Probably. His work in chronic pelvic pain has led to new awareness of these conditions, updated definitions and classifications, validated outcome parameters, and recently new diagnostic paradigms. So thank you so much for being here, Dr. Nickel. I know you are a very busy man, as we were just talking just briefly before, and he was telling me about all his projects. So I wanted to start off. Go ahead.
Nope,
Oh, you look like you wanted to jump in. So no.
Well, jump in when you ask the question.
Okay. So I just wanted to start off by, I'm curious to know what led you to researching and treating IC patients, because you are few and far between. So.
Well, Marnie, thanks for asking me to be here tonight. I always love presenting and talking to patients. In fact, one of the best experiences we ever had in Kingston was we had an open cafe at one of the restaurants and booked it for 20 patients to come in and talk to us in a round table, and we were inundated. So I know this is a topic that a lot of patients are very cognizant of and would like to discuss in further detail. So it's great to be here. I thank you for the invitation. So how did I ever get involved in interstitial cystitis, pelvic floor problems, pelvic pain, and urinary tract infections? Most urologists don't want to do that because, for the most part, it's not surgical. And urologists such as myself make our living doing surgery. So, I could only do this as sort of a hobby or a research interest on the side. I still had to operate on prostate glands and bladder cancer and kidney cancer and the other to make a living. So my background is in microbiology, and microbiology is infections. And when I saw patients early on in my career, I really did believe that patients with males with chronic prostatitis, which is somewhat similar to, interstitial cystitis, and patients with what we called then interstitial cystitis were really having an infection. And the fact is, we just weren't finding the bug or bugs that were causing the infection and the symptoms. And at that time, when I started, they just discovered the bacteria, the Helicobacter pylori, that caused gastritis. Gastritis, when I was in surgery, we removed the stomach because we thought that, it was an ulcer and this sort of thing. When we found out now, the majority were caused by this bacteria that nobody had ever discovered before. So I wanted in my career to discover that microorganism that caused interstitial cystitis or chronic prostatitis in men or both. And I spent, literally millions of dollars and studied hundreds, if not thousands of patients to try and find that organism. And sorry, I've just lost you. For some reason, my computer just went blank because
You were still there.
Yeah, it figured I wasn't doing anything, so it went to sleep. So, I figured that the new technology. So I started out using the standard techniques, culture, and then electron microscopy. And now we have this next generation sequencing by companies that can actually look for bacterial DNA. Used all those technologies. And unfortunately, I came to the conclusion there was not a single bacteria or a couple bacteria or viruses working together to cause the majority of these symptoms. And
Hmm.
that's how I got into it. Now, I did find that for some patients, infection is what caused interstitial cystitis, bladder pain syndrome, and propagates it. But we also found that that's, a fraction of the patients that are suffering. Maybe 10 to maximum 16% of my patients actually have what's called an infection phenotype. So that's how I got into it. Um, I found out that if I couldn't treat an infection, I had to find out how else could I treat the many patients who are suffering from bladder pain, urgency and frequency associated with it. And that led to about 20 years ago, opening up an interstitial cystitis clinic so that I could better evaluate the patients in sort of a multidisciplinary approach and better be able to treat them, because I would dedicate time and space to treating women and men with this condition.
Okay. Yeah, no, it's amazing that you are doing this work because, like I said, I mean, I have IC. I was diagnosed over 20 years ago, and it was always such a conundrum. And I feel like, the doctor that I did see, Dr. Leslie Carr, is now retired, and people in Toronto, Ontario, Canada, really struggle to find urologists who will help with IC because, like you said, surgery is the moneymaker, and that's where most doctors want to be.
Well,
Um,
let me tell you a story about that, because we opened our clinic and we're doing very well. And then we were starting, people heard that we had a clinic in Kingston and Toronto, Ottawa, and elsewhere. The doctors wanted to refer to us. And
mhm,
so we decided we would expand. I had
mhm,
a very good staff of nurses. We said, okay, this is an unmet need. Let's do it. And
mhm.
we opened it up, and I sent around an email to the urologist in Ontario saying, I'm willing to examine your interstitial cystitis patients. Within 2 weeks, we had 350 new referrals. I
Unreal.
had to stop it after 2 weeks. It took me over 2 years to be able to see those 300 and some patients. So I know what you're saying. There's a huge unmet need. In fact, Leslie Carr, who I have great respect for, uh, she found it daunting to be signaled out in Toronto as a person to do IC, and it became very stressful for her because people were referring too many patients to her. She did try and do what I did at women's college, and that worked for a
Yeah,
while and then kind of fell apart because of lack of funding.
funding. That's right. I remember her telling me about that, and it was very discouraging,
Yes.
to hear that, because there are so many. And the one thing also, chronic prostatitis, would you say, because, they're always saying that there are, the stat of women having IC is so much higher than men. And they almost say it's like a women's condition. But would you say a lot of people who are diagnosed with chronic prostatitis should actually be diagnosed with IC? And
No, not necessarily.
okay.
Um, But some are, and some are misdiagnosed. So those
Yeah.
people that are misdiagnosed, they're diagnosed with chronic prostatitis, but in fact, what they're complaining of is pain as their bladder is filling and the need to urinate to relieve the pain, so they have frequency and urgency. The chronic prostatitis is more of a painful condition of the pelvis, pelvic floor, external genitalia, and it can be associated with frequency and urgency, but not necessarily related to bladder filling or bladder recycling, we call it.
Mhm.
So they are different. And why that's was an important question, Marnie, is because about 15 years ago, it was at a conference in Washington, D.C. It was decided that there were so many similarities between men with prostatitis and women with interstitial cystitis
Yeah.
that we would call it urologic chronic pelvic pain syndrome, or UCCPS. And for a decade, we were looking at men and women together as a single sort of disease or syndrome entity. It's only now we realize that that's not the case, that the men and the women have different processes to get to where they are with us. They have to be looked at different, evaluated different, and yes, treated differently, unless you have like an obvious case of a man with Hunter lesion interstitial cystitis, then he's treated the same as a woman with Hunter lesion interstitial cystitis.
Right, which is the only one that can actually be exactly diagnosed. Like, yes, if you have Hunter's lesions, you have interstitial cystitis.
If you have Hunter lesion, you actually have a disease, and a disease can be tackled. And we know how to treat Hunter's lesion, not cure it, but treat it. Unfortunately, the other 85 to 90% of patients don't have Hunter lesions, and they're the ones that we need to spend a lot of time on understanding better.
But those lesions often come back. Like, it's usually they have to be constantly cauterized, correct?
Oh yeah, it's not a cure to cauterize them, and that's why I tend, after the first cauterization or two, to inject with steroids. Triamcinolone, which is injected directly into the lesion, causes less trauma, less pain, and for many patients, it gives the same response as repeat cauterization. It also causes less eventual damage to the bladder, as repeat cauterization, of course, can cause fibrosis, scarring, and worsening of the small capacity bladder.
Right. It's a tough one. So what are your thoughts on the effectiveness of intravesical agents for IC? I know that certain combinations of agents are better or worse for certain patient phenotypes. So I want to get into the phenotypes as well, because I know that came out late last year, and it's now a big part of IC and how we basically categorize people, right, who have the condition. So yeah, let's first talk about the intravesical agents and how you work with those, and if you think they're beneficial, and how they're beneficial, and who they're beneficial for with respect to those phenotypes.
Right. So every one of my patients who sees me would like a magic pill that they would take and it would solve the problem. And for some patients, we find that magic pill. Sometimes in the past, it could have been Elmeron, could be amitriptyline, could be hydroxyzine. And we find the pill that works well with them. And if that works, that's great. But for many patients, we have to do intravesical therapy. Now, before giving anybody any medication or intravesical therapy, we do a lot of self-help and self-treatment. Number one is education, so the patient understands what's going on. Number two is dietary manipulation. Patient trying to understand how dietary and environmental things impact their bladder, and then make sure that those are out of their diet. The patient figuring out how stress and anxiety, plays a role in flares and ongoing symptoms, and the real ameliorative effect of exercise, just any type of exercise, walking, whatever, and exercises. And the exercises can be mind exercises, like mindfulness, or they can be exercises such as yoga and stretching exercises that are helpful. So every patient has to have that before I'll even consider a pill, and before I'll consider intravesical therapy. Now, intravesical therapy is, unfortunately, probably the mainstay of getting my patients out of trouble. Over 50% of my patients will end up at some point having some type of tailored or directed, personalized program of intravesical therapy based on the history, their previous experiences with other treatments, and what we figure out is their clinical phenotype, and that helps us figure out mechanisms that we'll try and address with intravesical therapy. And so we have lots of different therapies we can use, and we can use them in combination or sequentially. So it gives us a lot of treatments in our armamentarium treatment cupboard that we can pick out for each patient as we tailor a personalized treatment program. And like I said, in over 50%, that will be an intravesical therapy. And in Kingston, 99% of the interval therapy is done in our clinic.
Mhm.
The odd patient, and I don't mean odd, with some patients electing to do their own therapy at home.
Mhm. So if they can self-catheterize, obviously they have to know how to do
Right.
that too. Yeah. Okay. So why don't we go back to talk about the phenotypes, because you did have a study that came out late last year, and it has 9 phenotypes or subtypes that have been defined. So maybe you can elaborate on how and why this came about.
So how it started is we realized that the guidelines, and that's the Canadian guidelines, the US guidelines, and European guidelines for many years, had a stepwise treatment program. You try step 1. If it doesn't work, you stop it. You try step 2. If it doesn't work, you stop it. You try step 3 and work down to finally, nothing works or something has worked. We
Mhm.
realized early on that stepwise, monotherapy didn't work. We realized that patients responded differently to different therapies. And we realized that sometimes multiple therapies given at the same time might be better than a monotherapy. So we developed a phenotype type description, realizing, and we call it the snowflake hypothesis. Though every patient kind of presents with similar symptoms, they all are different and unique. And we started this with males with chronic pelvic pain syndrome, chronic-prostatitis, and we called it U-point. And U-point had 6 phenotypes: urinary, psychological, organ-specific, infection, neurogenic, and tenderness, which really meant, pelvic floor muscle pain.
Mhm.
We had to find something, so T was the one that worked. And when we categorized men and treated those specific categories, we did very well. 80 to 85% of men did extremely well by using U-point. Now, when we used U-point with women, we had some success uh, with interstitial cystitis, but not near what we had with men. And we soon realized the U-point didn't work because there was U, which was the urinary symptoms, and O, which was the organ specific. To be called interstitial cystitis, you had to have, organ specific, that's bladder pain, and you had to have urinary symptoms. So already everybody had 2 of the 6, and then it became a little bit different. That was about the time we started to realize that patients could be divided into bladder pain only,
Mhm.
regional pelvic pain, and widespread pain.
Mhm.
That later became pelvic pain and pain beyond the pelvis. And now we've found out that probably the best way to look at it is patients presenting with only bladder pain compared to patients with widespread pain. In other words, they have pain beyond the bladder, such as irritable bowel syndrome or fibromyalgia or the like. And we started treating patients that way and had better success than we had with U-point.
Mhm.
Then we realized that was too simplistic. Our patients are more complicated than just bladder pain alone or beyond the bladder, like widespread pain. So we started to look at the different phenotypes. And you mentioned this was a study. It really wasn't a study. It was more my personal experience. And as I'm transitioning into retirement, I wanted to leave something for other urologists and physicians to have a better understanding of these patients. So I wrote that paper as more of a cookbook approach to try and understand how to treat the multiple types of patients we see. So in my practice, I see basically 9 major phenotypes, but because the patients can have 1, 2, 3, 4, 5 or more of those phenotypes in their individual presentation, it's unlimited, the number of presentations. And that's what makes this so good, is what you do is you categorize the patient. This is what I'm telling physicians, trying to teach them, is
Mhm.
try and categorize a patient towards these presentation phenotypes, and you can develop this categorization without any fancy blood test or urine test, because we don't have any for IC. It's
Mhm.
based on good clinical studies. And that's how I came upon this. And if I was 10, 20 years younger, I would be doing the study, Marnie, that you said, and it would be a massive study. I would try and get every Canadian urologist who saw IC into it, and we would do this study to see how well we could manage patient with individualized treatment program. Unfortunately, I'm heading to retirement, and we'll
Mhm.
see whether or not others will take it up. But it has resonated with urologists who deal with this syndrome.
Mhm. Are you finding there to be enough people out there, enough urologists, urogynecologists who are helping those with IC, or would you say there's not enough help for them?
That's an easy answer. There's near not enough.
No.
Even in Kingston, where we have a established clinic, it still takes a long time to get in to be seen in our clinic. It is probably so much worse. And I've heard horror stories that patients are end up waiting longer than a year to be able to see somebody, and then they're seen for 10 minutes and given an antibiotic or Valium or some
Yeah,
ridiculous treatment,
I see it all the
sent
time.
on their way.
Yeah, it's terrible. And it's almost treated more like a psych condition than anything else too. Uh,
You'd think we'd learned our lesson long ago. Now there are a lot of psychological uh,
Components.
things that happen, but
Yeah.
it is not a psychological. It is real pain, and real pain
Mhm.
brings out different psychological coping mechanisms in different patients. So we in our clinic, we actually use the psychology that the patient is presenting with, particularly in a psychopathology, and we try and identify the maladaptive coping of the patient and try and improve that, sometimes through cognitive behavioral, but sometimes just through education.
Mhm. Mhm. I think a lot of people just have to understand how the brain works and how pain stems from the brain. And I think a lot of people just assume that when their pain is, they're feeling pain in a certain part of their body, and then you say, well, you got to work on up here. They start to say, no, I'm not. It's not in my head. I feel it here, and they can't seem to tie the two together. Um, that the brain and the bladder work together, right? Mind over bladder. So it's a big thing, and I think it's huge that people have to sort of figure that piece out to get to the next step, right? Um,
Yeah, no, pain is real, and for
oh,
the patient, yes,
absolutely.
it is really real. But yes, part of the as you said,
Yes.
part of the thing is how to manage that pain so that you get some quality of life and you can do activities that you want to do,
Mhm.
particularly if the treatments aren't, the medical treatments aren't working as well as you would like.
Yeah. And I think, like you said, I mean, I don't know, we haven't discussed your take on the biopsychosocial approach, but it sounds like when you take this phenotype, when you look at the phenotypes, we sort of need that multifaceted approach to help people get to a better place who struggle with IC.
Well,
Um,
I've been blessed. My last two IC nurses and my prostatitis nurses all were very empathetic people who understand pain. And what I was able to do is obtain the funding, so they had the time to
yeah.
actually discuss the issues with the patients. So I probably saw the patients no more than any other urologist in terms of time, because all the groundwork and I think a lot of the treatment was done by my ancillary staff, the nurses
Mhm.
who took the whole story, and then I just helped put together the steered everybody towards a treatment program that I thought might work. But
Mhm.
yes, the biopsychosocial aspects of this disease are paramount in not only understanding but in using them to manage patients' pain and activities.
And I think that when people start to realize that, with the shortage of urologist, conventional medicine dealing with IC, knowing that they can look to many other things is helpful, right? I
Yeah.
mean, you can do pelvic physiotherapy, which is helpful for so many people, especially the ones who have the pelvic floor dysfunction, the hypertonic pelvic um, floor, right? So
Yes.
they go for pelvic PT. If they have dyspareunia, all those things, it's helpful. Figuring out what works for you mindfully, whether it's restorative yoga or it's doing meditation, tai chi, qigong, whatever it is, just figuring out what works for you. That's what we focus on the site, helping people navigate that whole system and understanding.
Well,
Uh,
I found that the support groups, you
mhm,
know, patients supporting each other and patients becoming self-educated and then
mhm,
teaching others how to
yeah,
manage is so important in
mhm,
this type of an enigmatic disease where physicians don't have, I was going to say, don't have all the answers. They don't have very few answers at all. So sometimes the patients have to sort of bind together and work out some of these themselves. And, support groups have been very, very good.
mhm,
And I've met so many experts who become self-experts through learning,
yeah.
perhaps like yourself, who are able to impart this important knowledge onto other patients suffering from the same condition.
Yeah, I mean, that was the whole thing, right? For me, it was like I felt isolated. I didn't know anyone else, 20 years ago who had IC. I didn't feel like I had anywhere to turn. Dr. Carr was booked for like 6 months in advance if I needed to get in to see her. It wasn't possible, right? So I kind of had to navigate the system and figure things out on my own. And then hence I created the site as a result, helping other people figuring out the system. Um, so yeah, so I wanted to touch on one more thing before we get into the questions. But I wanted to talk about the new treatments that are on the horizon for recurrent UTIs. I know that you are working on a very exciting vaccine, MV140. So I'll let you take it away on that.
Right. Right now, in May 25th, I believe that's the date today,
Mhm.
we don't have a vaccine that we can use in Canada. So what can we do? Well, evidence has shown that simple things like just increasing fluid intake
Mhm.
can make a drastic change. The use of intravaginal estrogen in postmenopausal women can help many patients. D-mannose in patients who have recurrent E. coli UTIs may be a benefit. Cranberry, extract,
Correct.
particularly cranberry extract that has a validated PAC uh, uh, concentration. I think over 30 milligrams, 36 milligrams is even better, is what we'd like to see for anti-adhesion. The use of probiotics, particularly in patients who have been on multiple antibiotics, can
Mhm.
be a benefit. All these things are what we use right now.
Mhm.
There are other, dietary things that might be a benefit. Certainly, there's a lot on the internet, very little proof, but not one of them is an unhealthy choice. So
Mhm.
all those are things we can do right now in trying to avoid, multiple courses or long courses of preventative antibiotics.
Mhm.
Now, recurrent UTIs in women is a major problem.
Mhm.
11% of women every year have a UTI. 3% of women have more than three every year, average being around six for that group, which can make a pretty, difficult life, being on antibiotics that many times a year or being put on antibiotics for long periods of time in excess of 6 months and longer. Causes all sorts of problems with the
Yeah.
patient's health because of the change in the microbiome in the gut. So I became interested in vaccines long ago, like 20 years ago.
Mhm.
And most of the vaccines have not been very successful. Eurovaxum is one that's available in Europe that is reasonably successful, causes no harm, and many patients have found a lot of benefit from it. I've never really had much experience with that.
Mhm.
About 8 years ago, I became aware of MV140, which was called Urimune in Europe, which was being used on special access. It hadn't been approved anywhere, but studies were being done, particularly in Spain and in the UK, that showed efficacy. So I became involved in the largest study, which is a randomized placebo-controlled study in over hundreds of women randomized to either taking the vaccine or placebo. And we published that in the New England Journal of Medicine evidence just recently. And the patients who were vaccinated did extremely well. They went from, a median of 6 UTIs per year to none in about 55 to 58%, with a 75% reduction overall in UTIs. And the
Wow.
patients who were vaccinated who had a UTI, the symptoms were less severe. So I became very so optimistic that this might be the next big thing for women, a real game changer. So I pursued Health Canada up and down the Ottawa halls till finally they gave me permission to be the only physician in North America be able to bring Urimune into the country and try it on my patients. And we used Urimune in 64 patients in a Health Canada approved trial. And what did we find? We found the same thing as the RCT. In real life, maybe not quite as good as in the major study, but still patients went from an average of 6 UTIs to 0 in over 40% of the subjects. Well, we had an overall reduction in 80%. 80% of the patients thought they had done much better because their not only their infection rate went down, but when they got an infection, it wasn't as severe. Many of the patients with a UTI didn't even want an antibiotic. Managed the UTI without an antibiotic because it wasn't as severe. Now, what you might be interested in, Marnie, in that particular group, we had 16 patients with IC who had an infection phenotype. In other words, they were having recurrent urinary tract infections that were causing flares. And I believe, based on some of the studies we've done and published, is that those patients, their IC was hypersensitization to the recurrent UTIs. So we had 16 patients. I presented this in Chicago at the AUA, that's the American Urological Association meeting last month. Of those 16 patients, 8 of them became UTI free. Sorry, more than that, 12 became UTI free. 8 of the 16, that's half, they're resistant to treatment. I see completely resolved. And I mean completely. These are women that their life changed. 20 years of IC and 12 months after finishing the vaccine, they were more or less cured. In other words, no pain, no urinary urgency. 12 of the patients of the 16 did have significant response in reduction in IC symptoms. So I think there is a type of interstitial cystitis that's caused by bona fide recurrent urinary tract infections. And vaccine, I believe, will be, a real breakthrough for that small population of IC patients.
Then they won't have to take the long-term antibiotic protocol that some doctors have been
Right.
prescribing. Yeah, I was never one to say much about that because I just thought when I heard 6 months of antibiotics, I just,
Well,
oh
in
my
some
gosh.
places, people are advocating, a year of full dose antibiotics for patients with culture negative, like no UTIs. Well,
I've
my
heard 2
gosh,
years
that's a
sometimes.
way to make people really, really long-term
Sick.
ill. It's going to have ramifications in terms of future cancer, rheumatoid arthritis, all mental, everything, because it completely disrupts your healthy microbiome in the gut everywhere. And it is such a disaster to see patients being put without proof of an infection on antibiotics, full dose antibiotics
Yeah.
for a year. That's scary.
I just don't even think people understand how, you know, strong antibiotics are. I mean, they kill all of the bacteria. So we're not like it's good bacteria too. And I think people, people need to take probiotics, obviously, when they're taking antibiotics to try to replenish the flora in your gut. But it's just like when you hear of just the thought to me of being on antibiotics I've heard people even on it for 2 years. There's been some people
Yeah.
who've been on it, and
Well,
I'm just like, "Oh."
Marnie, just go back 100 years or late 1800s, 1900s, patients presenting with a UTI and interstitial cystitis, which was available at that time. You know what they were prescribed? They were
Mm.
prescribed tincture of arsenic, tincture of lead,
Oh my
opium.
poison.
This
Yeah.
is strychnine, small doses, not enough to kill you, but this is what they were given.
Oh,
Uh, and you know, many women did very, very poorly. Some were even killed. Uh, and if that didn't work, they bled them. You know, they bled them down to being anemic, and that was the treatment for interstitial cystitis or cystitis, recurrent and chronic cystitis. You know, back in the good old days. Well, antibiotics are the same type of thing. Patients may feel that they're getting better, but in fact, you know, it's causing. Now,
good.
antibiotics are lifesavers. If you have an infection,
Yeah, of
acute
course.
infection, and you're miserable with it, antibiotics are the thing. You
Strep
have
throat.
complicated UTI, you could die from an infection.
Sure.
If you have a
Go to
lethal
your kidneys.
infection,
Yeah.
you need antibiotics.
Mm,
Antibiotics are lifesavers. It's
yeah.
just that, you know, what we're doing is we're actually feeding it to our livestock and our chickens in the water so that we get, you know, healthier beef and chicken, which when in reality we're just causing antibiotic resistance so that when those bugs cross over to humans, we have no antibiotics to use.
Yeah. Ugh. Is MV140 an mRNA?
Say again?
Is MV140 an mRNA vaccine?
No.
No, okay.
It is a really totally different concept. One that, you know, Health Canada is having trouble getting their head around because one that's never ever been presented before. Basically, it's very simple. It's bacteria that cause UTI
Yeah.
that are killed, put in, it's a very nice emollient that, you know, is very safe, and then
Yeah.
a tincture of pineapple. It's sprayed under the tongue rather than injected. And it's like getting an infection. And what we've learned is by spraying it under the tongue through the innate immune system, and there's also some what's called adaptive immunity and some other types of thing through the lymph system, not through the bloodstream like you get with mRNA or injection, through the
Right.
lymph. It gradually, over 3 months, immunizes all the mucosal surfaces, including the urethra and bladder, against those bacteria. It's phenomenal. What actually happens.
Oh my
There's
god.
no other vaccine like it really being used in North America.
Huh. So is it on its way or
Oh, I hope so.
yeah.
But there's so many roadblocks in,
Of course.
and I'm just finding those out.
Yeah.
But so many roadblocks in getting a vaccine uh, approved in North America. So it's approved in Mexico and other places. It's being used in the UK, Australia, New Zealand, Spain, Portugal, about 17 countries now. Not North America. The vaccine rules are so strict, and I know Health Canada knows this is a huge unmet need. I know they understand that it works. I know they understand that it's safe for patients, but the idea of spraying a vaccine under the tongue and with dead bacteria and immunizing the bladder is foreign to immunologists that are in Health Canada right now. So it's going to be longer. I thought it was going to be you know a
Mm,
no gamer. I thought everybody would see what I see. The huge improvement in patients, the huge unmet need, the fact that it's so safe, but
mm.
there's a it has to go through the same approval process as every other vaccine. And because recurrent UTIs are not COVID, people aren't dying from it. There's no rush on Health Canada's part to to approve it.
It is
So
costing
uh,
healthcare in Canada a lot of money when people are constantly going in to get their urine samples checked,
oh, you're talking to
and
the
the
converted.
emerge and I don't know. I see a need, but yeah, I get it. It's not life or death. So yeah.
Well, I think what could change it the same way in politics in the States. just some of those, immunologists in Health Canada, their sister, their mother, grandmother, or wife suffers from recurrent UTIs,
Yeah.
and they know that this vaccine is safe and effective. I think they might have a little bit of change of heart, and they might help expedite the process,
Really.
like they did with the COVID vaccines.
Yeah.
But
Sick.
I'm just like a little clinical cog in a big wheel, and what I wish and hope for, plays no role in what eventually happened.
Yeah. Well, I wish we could talk forever, but I feel like we should get to some of these questions here. So Heather asks, what needs to be done to create a new generation of IC doctors? Patients presenting to med students about how this would be a good area to practice, lobbying government for funding.
That's a difficult question because we're already having a major problem with medical students not selecting family practice as a vocation. And that's a major, major issue because we've got to stop medical students from going into specialties. We have too many orthopedic surgeons who are graduating, neurosurgeons, cardiovascular surgeons, and they're all going to practice in the United States. What we need to do is have Canadian medical students want to choose something that's a little bit less sexier, and that's family practice. So at Queen's University, we are going through a program, experimental, of choosing medical students early on who express an interest that they would like to go to medical school to be family physicians, and then streaming them that way. Now, can we do that for specialists in urology and urogynecology? I thought it was possible, but for years I had funding to train in our IC clinic to train urologists who would be interested taking this up as a career. Very, very few takers. One of the few takers I have is Dr. Chris Dwyron, who's taken over from me, and he's taken over my clinic and will change things and improve things over what I did. But he is a very rare individual who can see that there's an unmet need and that he can help fill that gap. But he also has to make a living, so he has to see other patients. He has to see prostate patients and bladder patients and cancer patients. Otherwise, he doesn't make a living. And there's the crux of the matter. The way the funding situation is right now, you can't make a living seeing chronic prostatitis, IC patients, seeing patients with recurrent urinary tract infections. It just doesn't work. So, and nobody's going to really change that because nobody at the higher ups put any priority on those black sheep sort of ignored diseases of the urinary tract. It's depressing.
It's like legal aid, basically.
Yeah.
Because people want to make money.
Well, the thing is, patient or medical students go into the surgical specialties because they want to operate. And their mentors, their main mentors, as mine was when I was in urology, was the busiest surgeon, because that's the one we wanted to be. We want to be the surgeon. We wanted to operate on patients and make them better and cure them. And then they go to clinic and see some IC patients. There's no major operations. Once in a while, you remove a bladder, but that's not any fun in these patients. So there's no major operations. The results aren't that good. Nobody understands. They don't even know if it's a disease. And the treatment is far from effective unless you sort of put together this cookbook approach and personalized patient approach that I advocate. And so what I've been doing over the last little while is very difficult to find very many. Like there's a physician in Halifax, a urologist. There's a urologist in Quebec City. There's a urologist in Montreal. No urologists in Toronto. None really in Western or McMaster. But what I'm trying to do is teach the general urologists how to better treat patients. And that was the approach I decided that I would take in the last decade. So I've been trying to teach physicians more about the disease, more about how to treat the patients who present to them, and to see these patients in between their surgical patients. And that's what I've been trying to sort of progress that way.
Okay. So it's complicated. clearly.
Clearly, very complicated.
Yeah. What do you think about the use of supplements? Deb asks.
So at the CUA this year, I'm presenting cautionary tales of supplements. Supplements for me are a major problem because I have nothing against them. If they're properly validated and done properly, they are very safe, and some of them might even be effective. And certainly they're as good as a placebo, which works extremely well. Patient believes and wants it to work, it'll be of some benefit to them. The problem is in North America, 1 in 5 supplements that we buy on the shelf are adulterated with pharmaceutical products. In other words, chemicals and medicines to try and make them work a little bit better. So, and some of these are caught by FDA or Health Canada. They're given a slap on the wrist and told them to take off the shelves. They're not, because there's no enforcement. They're still on the shelves, or they rebrand them, put them in a different box and call them by a different name, charge a different amount. It's extremely difficult unless the patient is willing to do some research. And what you have to do is make sure that the supplement you are taking has been certified by a certifiable, dietary supplement organization. And there are a number of those that are available, anything from USP to NFP, and there's a bunch of them that do it. And you can look it up and find, and consumer, what is it? There's a consumer one, but there's various ones that I look up. So if a patient brings a box to me, I will look it up and make sure that what it says is in it is actually in it. The majority of supplements in North America, the majority, way more than the majority, are made in Asia, primarily China, and some in India and Africa. And they're made in pots in people's basements and garages. And then they're put in very nice jars. They're put in with testimonials. They have nice boxes. And then they're bought by distributors in Canada, rebranded or not. Next thing you know, they're on health food and drugstore shelves. So supplements I have no problem with, but you've got to make sure it's certified and or validated. And what you're actually getting in the product is what they say you're getting, and nothing more and nothing less.
So do your homework.
Yes, make sure what you're taking has been tested.
Mm-hmm. So Pauline Reynolds, she says, I've been so blessed to be one of your patients and be part of the programs you initiated, and your nurse practitioners have been such a big support to my journey with IC. My infection rate went right down along with using hormone replacement. Great.
That's good. Then see, that's one of the reasons I stayed in the business, because I will get feedback like that, maybe in half of the patients, 60%, 70%. And that keeps me going. Unfortunately, not everybody has as good a story. And no matter how hard I try, and we do try, patients aren't getting as well as they would like.
Mm-hmm.
And so, well, this particular patient did quite well. I start off with the premise with most patients saying, we're going to go for small improvements. We may not cure you, but we're really going to try hard to work with you to get you somewhat better, get you doing what you want to do, and help you manage your life a little bit better. Even if we don't cure you or make you as good as you wished you had when you come to my clinic. In other words, we try and reduce expectations.
Mm-hmm. Mm-hmm. Yeah. Thanks for sharing that, Pauline. And okay, Heather was just wondering, but I think we kind of went through this when the vaccine will be available in Canada. It's TBD. It would help with antibiotic resistance to surely reduce prescribing hugely. That is important. Can you explain the neurogenic hypersensitivity subtype? Is it a problem with nerves in the bladder and elsewhere? And is there something wrong with the mucus?
Yeah, the sort of the hypersensitivity is, quite difficult to understand, but something happens in a patient's bladder. It could be infection, it could be trauma, it could be surgery that damages the nerves around the bladder. It could be dysfunctional voiding that's causing it. And what happens, and it doesn't happen in everybody, and we don't know why, is the nerves in the bladder become hypersensitized. and they start to feel pain and sensation when they're not supposed to. See, your bladder is supposed to just stand normally, and you're not even supposed to feel it. But the nerves now are sending signals as your bladder is starting to fill and saying, oh, I'm not enjoying this. It's getting worse. Or the hypersensitive nerves are starting to react with stuff that you eat that's just and that gets filtered through the kidneys and into your urine that normally you should be able to eat and just pee out and nothing happens. So it becomes hypersensitive. But then what happens is these sensitive nerves go back and send the signals to the spinal cord, and the spinal cord interacts with nerves that run up to the brain. And when that happens, we have what's called central sensitization. All of a sudden, the nerves are sensitized beyond the bladder. And then the brain sends down messages to organs nearby and elsewhere, like muscles, bowel, brain, headache, ears, even, to your teeth, anywhere, and say, maybe you guys should be sensitized too. And we start to get this widespread pain. And the best way to treat that is a type, all we could really do is neuromodulation and medical neuromodulation. And that's why in some patients, the increasing doses of amitriptyline or similar, or the use of gabapentinoids such as gabapentin or Lyrica can be, that's pregabalin, can be a benefit. It's very difficult. And we see in studies of the brain, the patients that started with bladder sensitization and then end up with central sensitization actually get almost semi-permanent changes in the brain that take a lot of time and effort to mitigate. So the first thing we have to do is decrease the sensitization in the bladder. And the way I do it in our clinic is with intravesical therapy, like we talked about, and we use a combination of intravesical lidocaine, which is what we use to freeze the teeth at the dentist, and bicarb, which is just bicarbonate to alkalize the urine and let the lidocaine settle onto the bladder wall. That we find can, if we do that on a regular basis, like weekly, can sometimes desensitize the bladder. And over time, maybe reduce the central sensitization, particularly if we add, the tricyclic antidepressants such as amitriptyline or one of the gabapentinoids such as gabapentin.
I have a question about amitriptyline, actually. I've been on it for a very long time, and I've lowered my dose, and I really would like to get off because I'm thinking, there has been some studies showing that anticholinergics can cause long-term mental decline, so it can lead to dementia. I take a low dose, 10 milligrams, but just wondering if, being on it for 20 years is an alarm.
So the anticholinergic effect from amitriptyline is very small.
Mm-hmm.
And a 10 milligram dose is, basically a child's dose.
Mm-hmm.
I don't think you really have anything to worry about, but always less medication is best,
Mm-hmm.
as long as you don't revert like you did before, it doesn't do the thing. So, you've been on amitriptyline for 20 years, a vacation from amitriptyline. So a drug holiday is not a bad idea. The only thing is you have to go really, really slow. So if you're going to do it, you want to cut down, say, I'm going to try and get off amitriptyline. I've been on it for 20 years. I'm going to get off it, but I'm going to take 6 months or longer to get off it.
Yeah.
And you can cut it down to, like, I have patients go from, you go 10 to 5 to nothing, but you can cut it down even more than that. You can go 10, 7.5, cut the pills in half, go 5, 2, and then cut the pills in half, and then gradually over time, go off it. And then if your symptoms, you're convinced your symptoms are all coming back again, you can always go back on it. You always give yourself a little boost too for a while.
Mm-hmm.
But yeah, it's always better if you can be off medication, you're better off, but not at the detriment to your quality of life and having pain return and all that sort of thing.
Yeah. Well, like you said at the beginning, some people have a great benefit from drugs, like you were saying, I guess is it Atarax? The one
Cataracts,
that, yeah,
hydroxyzine, yes.
hydroxyzine or amitriptyline or gabapentin, and for me, it was amitriptyline, and I do notice a big difference because sometimes I'll go, one night I won't take it, and then the next night I'll take it, and I'll just try to go every other day, just to see if I can
Yeah,
tolerate
if I were you, I'd cut down the dose rather than alternate.
doing the every other. Yeah,
Slowly go
slowly,
off it because you've been on it so long.
so
Your
long.
body is just so used to
Used to
having
it
it there.
for sure, for sure. Well, if that's all the questions, I just want to say thank you so much. This was so insightful, and just it was such a pleasure and a treat to have you with us this evening. I think this will benefit so many in the IC population. So thank you, thank you, thank you. Thank you also to Red Leaf Medical for sponsoring this. What should I call it? Podcast, YouTube Live. And we really appreciate that you pulled through for us. And that's tonight. So thank
Thank
you
you.
for joining us. And if you have any further questions, we can, people can post them in YouTube, and we can address them as they come.
Okay.
Yeah.
Well, thank you very much, Marnie, and
Yeah.
thanks for anybody that was interested in listening. Bye now.
Yes. Bye.